Good evening, everyone. Today's topic for presentation is hyponatremia. It is a case-based presentation with a bit of slides of cases and theoretical discussion about hyponatremia. So, first of all, we should know why we are discussing the sodium concentration with, spending so much of time, and because it is a kind of most common disorder of fluid, body fluid and electrolyte balance. Means approximately almost 22% of patients who are hospitalized do have some sort of sodium imbalance, and mismanagement of sodium imbalance can lead to increased mortality and morbidity in patient, and can also sometimes cause permanent disability in patients. So, to introduce, the disorders of sodium are mainly caused by the abnormalities of water homeostasis rather than sodium itself, which leads to relative ratio change in the relative ratio of water and sodium. So there are two major factors. One is water intake, and second is circulating ABP levels, that is ADH level, antidiuretic hormones. So, as far as water distribution is concerned, we know that water is distributed into two compartments. One is intracellular and another is extracellular compartment. So, intracellular has 55 to 75% of our water content, and the extracellular, which includes extravascular and intravascular component, that comprises of 25 to 45% of our water distribution. So, major intracellular particles are potassium, organic phosphate, esters, which include ATP, creatinine, phosphate, phospholipids, and major extracellular fluid particles are sodium, chloride, and bicarb. So, serum osmolality is calculated by the formula as shown, in which sodium is the major factor, and other factors are burn and glucose. So normal osmolality lies between 280 to 295. Anything above 295 or 300 is called as hyperosmolar, and anything below that is called 280 is called as hypoosmolar. Antidiuretic hormone has a very important role to play in sodium balance, as it causes water absorption. Whenever the body is having deficit in water, or is having hypotension because of intravascular volume constriction, the hypothalamus produces ADH because of the stretch of the osmoreceptors present in the hypothalamus, which gives signal to posterior pituitary to release ADH. This ADH acts on two receptors. These are V2 receptors and V1A receptors. V1A receptors are responsible for the vasoconstriction, which leads to increase in our hypertension, which leads to increase in BP, and V2 receptors are present in the kidneys, where they where stimulation of V2 receptors leads to increase in expression of aquaporin type 2 channels, which are responsible for reabsorption of water. So these two things are important in sodium balance. Just a second. So our case is a 35-year female who presented with altered sensorium since 4 to 5 years before admission. She had history of headache since 2 days, history of vomiting 7 to 8 episodes per day since 2 days, and she never had any history of fever, seizures, or focal neurological deficit. She was a known case of empty cellular syndrome since 2 to 3 years with hypothyroidism on thyroid supplementation. She was secondary to empty cell syndrome. She was a case of hypogonadotropic hypogonadism on treatment with estrogen and progesterone for fertility, and this time she conceived with in vitro fertilization, and was 10 weeks gestational age. On examination, patient was hemodynamically stable. There was terminal neck stiffness. There was no edema fluid. On CNS examination, she was stuporous, not following commands, and was withdrawing to DPS, moving all four limbs, no focal neurological deficit, and her planters were right was extensor and left was withdrawal. Pupils were normal. So, considering the history of steroids, I mean estrogen and progesterone, and in a young female with history of headache, vomiting, we first tried to rule out any central pathology. MRI brain plus phenogram was done, which was normal, and it was done to rule out the CVST and other central events. ABG was suggestive of sodium of 100 and 101, which was severe hyponatremia. So, patient was from here, the workup for hyponatremia started. KFTs were done, it was normal to rule out any renal pathology. Uric acid was 4.6, serum calcium, phosphorus were decreased. She was having hypocalcemia and hypophosphatemia. Serum magnesium was also low. Serum osmolality was also low, 211, as sodium was 101, it is 211, and urine osmolality was also decreased, 200. Urine spot sodium was 24. Thyroid profile and cortisol levels were normal. IVC screening was done, which was completely collapsible. So, considering all the parameters, we kept the diagnosis of uh, hypovolemic hyponatremia, and sodium correction was started at a rate of 3 to 6 milliequivalent per 24 hours, along with correction of other electrolytes. So,
Jayant, yeah, this one I was going to talk about that, whether there was
so
any predisposition to it. I think, okay, you carry on. Sorry.
So, sir, so this is on your left side of the screen. There is a normal image of a CT MRI brain showing the arrow pointing towards the sella turcica, which is filled, whereas the patient's MRI brain is on the right side, showing empty sella turcica. So this was the first MRI done when she came. So now coming back to hyponatremia, it is defined as plasma concentration of sodium less than 135. The causes could be increased circulating ADH leading to increased water absorption and causing relative hyponatremia, increased intake of free water, low solute intake, and most common cause is non-osmotic release of antidiuretic hormone. Hyponatremia can be classified into three depending on the serum osmolality, into isotonic hyponatremia, hypotonic hyponatremia, and hypertonic hyponatremia. The hypotonic hyponatremia is the main hyponatremia, which is the true hyponatremia, and we are more concerned about. And it can be divided into hypovolemic, euvolemic, and hypervolemic depending on the volume status of the patient, which we will deal in coming slides. So, isotonic hyponatremia. Isotonic hyponatremia is defined when the plasma osmolality is in the isotonic range, that is in the normal range 275 to 290, and it is usually due to marked increase in the serum lipid and or protein in the serum, which leads to decrease in the relative percentage of water. But the concentration of water and sodium is equal, leading to isotonicity. But as the relative concentration of water is reduced, leading to relative hyponatremia. So, as the proportion of water and sodium in serum is normal, it is called as isotonic. But due to relative decrease in sodium concentration in the total body water, patient depicts hyponatremia. So, it can also occur due to lab errors, and it can be avoided using specific ion electrodes and direct potentiometry. Second hyponatremia, that is hypertonic hyponatremia. It is labeled when the osmolality is more than 290, and it indicates presence of another effective osmol that causes water to move from intracellular fluid to extracellular fluid, leading to dilutional hyponatremia kind. Means leading to hyponatremia. The molecules which might be responsible for this are mannitol, glycine during TERP, and hyperglycemia. So the treatment is the causal treatment only, treat lower the sugar levels and stop mannitol. The third one is hypotonic hyponatremia, which is the true hyponatremia, characterized by a plasma osmolality of less than 275 milliosmoles. This is true physiologic hyponatremia that results from excess water due to ADH stimulation or impaired water excretion. And this is further classified into hypovolemic, isovolemic, or hypervolemic, depending on the fluid status of patient. So, in this type of hypotonic hyponatremia, the water flows from the extracellular fluid to the intracellular fluid. In hypovolemic hyponatremia, the total body water is decreased, and total body sodium is also decreased, which leads to the stimulation of ADH release. ADH then causes stimulation of V1A and V2 receptors, which lead to absorption of free water only, not sodium. So leading to relative decrease in sodium concentration. Now, hypovolemia can be due to renal causes or extrarenal causes. So to differentiate this, we do urine sodium. If urine sodium is more than 20, that means the kidneys are not able to retain sodium. So this can be due to renal losses, diuretic excess, mineralocorticoid deficiency, and all other causes. And if urine sodium is less than 20, that means the kidneys are trying to retain the sodium. So this can be due to vomiting, diarrhea, third spacing, etc. So, non-renal causes are GI causes, vomiting, diarrhea, tube drainage, insensible losses, third spacing. Pathophysiology of all above causes is reduced effective circulation volume leading to stimulation of E1A receptors or on baroreceptors causing vasopressin release and leading to free water reabsorption. So the treatment for hypovolemic is normal saline therapy, which inhibits the release of ADH, leading to free water diuresis and correction of sodium concentration. So other renal causes for hypovolemic hyponatremia, first is diuretics. So thiazide diuretics are more prone to cause hypovolemic hyponatremia because they act on DCT, whereas the furosemide loop diuretics acts on the loop of Henle. So when furosemide acts on loop of Henle, it decreases the medullary osmolarity and hence does not let and does not let the ADH act on collecting ducts. So the tendency of furosemide to cause hyponatremia is far less than thiazides. So when thiazide diuretics are given, this leads to sodium and water excretion, which leads to polydipsia and volume depletion, leading to decreased sodium and total body water is also decreased. So this again leads to increase in ADH secretion, which causes water retention and free water retention, causing again hyponatremia. And then second cause for renal cause is primary adrenal insufficiency, in which mineralocorticoids, in primary adrenal insufficiency, mineralocorticoids are more involved than the glucocorticoids, whereas in secondary adrenal insufficiency, glucocorticoids are more involved than mineralocorticoids. So mineralocorticoid deficiency, that is aldosterone deficiency, leads to decreased retention of sodium and water and increased potassium retention, leading to hyponatremia and hyperkalemia. So third is the salt losing nephropathy, which could be due to any of the following, like analgesic, reflux, interstitial nephropathy, medullary cystic kidney disease, tubulopathy following chemotherapy, post-obstructive or recovering phase of ATN. Fourth is osmotic diuresis, which can be due to osmotically active particles present in the serum, which in urine. The causes are glycosuria, ketonuria, and bicarbonate urea. The fifth one, that is most important one, that is cerebral salt wasting syndrome. It is a rare cause and is associated with intracranial disease such as subarachnoid hemorrhage, craniotomy, meningitis, encephalitis, traumatic brain injury. This is due to the release of BNP, brain natriuretic peptide, which causes natriuresis, leading to more excretion of sodium as compared to water and hence causing hyponatremia. So means marketed difference between cerebral salt wasting and SIADH is the first of all the volume status, that is cerebral salt wasting will be patients will be hypovolemic, whereas SIADH patient will be euvolemic. And another differentiating factor is serum uric acid, which is more than 4. So increased water loss and less load of sodium reaches DCT, which leads to activation of tubular-glomerular feedback, resulting in increased absorption of sodium and uric acid from PCT, proximal convoluted tubules. That's why the uric acid levels are more in or cerebral salt wasting. But whereas in SIADH, the sodium load which is reaching the DCT is normal, and hence there is no increased absorption, there is no feedback, tubular-glomerular feedback activation, which can lead to absorption of sodium and uric acid from PCT. So the third one is hypervolemic hyponatremia, which is due to increased extracellular fluid, but there is decrease in intravascular volume. So again, this decreased intravascular volume causes release of ADH and RAS activation, which leads to volume retention and causing hyponatremia. So hypervolemia, it can also again be differentiated into two depending on the urine sodium. If urinary sodium is more than 20, then it could be due to acute or chronic renal failure, and if urine sodium is less than 20, then it is nephrotic. It could be due to nephrotic syndrome, cirrhosis, or cardiac failure. Characteristically, the urine sodium in these three conditions is far less, approaching less than 10 sometimes. Then comes the euvolemic hyponatremia. So the patient of euvolemic hyponatremia will be euvolemic on clinical examination. That is, there won't be any pitting edema, there won't be any puffiness of face. So clinically, patient seems to be euvolemic, and there is primarily water gain is there, and total body water is increased because of the release of ADH, and again same, there is a decrease in serum sodium in spite of normal total body sodium. So this euvolemic hyponatremia, the main causes are glucocorticoid deficiency, hypothyroid, stress, drugs, and SIADH, that is syndrome of inappropriate response. So first is secondary adrenal insufficiency, in which the glucocorticoids are mainly involved. So in physiological condition, glucocorticoids have negative feedback on ADH. So when there is glucocorticoid deficiency, the ADH is the relative concentration of ADH is more, which increases the water retention, and it can be corrected with steroids like hydrocortisone. Second is hypothyroidism. So for every 10 milliunit per liter rise in TSH, there is a rise of 0.14, decrease in 0.14 millimoles of sodium. Thus, only severe cases of hypothyroid like myxedema coma will present with hyponatremia. And then comes the SIADH, that is syndrome of inappropriate antidiuretic hormone release. So it is the most common cause of euvolemic hyponatremia, and there are 4 distinct patterns which can cause SIADH. First is unregulated erratic ADH secretion. Second is failure to suppress ADH secretion at lower serum osmolality. Third is reset osmostat like in pregnancy, and fourth is no detectable circulating AVP, which is mostly seen in the loss of function mutation. So though the patient seems to be euvolemic, but subclinically patient is having expanded volume and serum uric acids are less than 4, because as explained before, there is no increase in uric acid absorption in the PCT as in the cerebral salt testing. So this is the pathophysiology in SIDH. So there is excessive ADH activity and free intake of water, which leads to water retention. This decreases the plasma osmolality and decreases the plasma sodium. This water retention leads to volume expansion, which decreases renin and decreases angiotensin 2 and increases renal perfusion. So increase in renal perfusion then leads to ANP secretion, which leads to diuretic, and this prevents edema formation, due to which we see patients in a clinically euvolemic state. Whereas this volume expansion, whereas subclinically patient is having volume expansion. So there is decreased aldosterone secretion also, and all these 3 factors lead to natriuresis. So in SIDH, there is water retention and natriuresis, which leads to hyponatremia. So the most common cause of SIDH are pulmonary disorders, which can be pneumonia, abscesses, tuberculosis, pleural effusions, and most common malignant disease associated with SIDH is small cell carcinoma of lung. The disorders of nervous system associated with SIDH are multiple, but most commonly encountered are subarachnoid hemorrhage, cerebrovascular accidents, traumatic brain injuries, and the most common drug associated with SIDH is SSRIs. So other causes are gain of function mutation in vasopressin V2 receptors, and then stress, pain, anesthesia, exercises. So diagnostic criteria of SIDH is, there are 6 essential criteria. First is effective serum osmolality should be 275, that is hypotonic hyponatremia. Second is urine osmolality should be more than 100 milliosmoles per kg. Patient should be clinically euvolemic. Urine sodium concentration should be more than 30 millimoles per liter. Absence of any endocrine insufficiency, adrenal, thyroid, pituitary, and there should not be any recent use of diuretic agents. If there is any use of diuretic agents, then a gap of almost 1 week is recommended before establishing the diagnosis of SIDS. Another supplemental criteria is serum uric acid less than 4 mg per dl, serum urea less than 21.6 milligram per dl, failure to correct hyponatremia after normal saline infusion, and other 4 factors which are not usually practiced. So SIDH versus cerebral salt wasting. So in SIDH, serum urea concentration is normal to low, whereas in cerebral salt wasting, it is normal to high. Serum uric acid concentration is low in both. Urine volume is low in SIDH, normal to low in SIDH, whereas it is high in cerebral salt wasting. Urine sodium concentration is more than 30 in both of them. Blood pressure is normal in SIDH, whereas patient can have orthostatic hypotension in cerebral salt wasting. CVP is normal in SIDH as patients are euvolemic, whereas in cerebral salt wasting due to hypovolemia it can be low. So this was difference between SIDH versus cerebral salt wasting. Now other causes of hyponatremia are low solute intake, which is usually seen in alcoholics, most commonly in beer, photomania, those who are only dependent on alcohol only and very less of nutritional intake, because beer in itself is very low in protein and electrolyte content. Second are T-toes diet, who only means persons who are only dependent on tea and toast for their daily meals are also expected to have low solute intake hyponatremia, and extreme vegetarian diets are also susceptible to this hyponatremia. So the lab parameters associated with this is very low urine sodium, that is less than 10 to 20, and very low urine osmolality, that is less than 100 to 200 milliosmoles per kg. So clinical features of hyponatremia. Usually, the primarily hyponatremia manifests as a neurological condition. So this is due to the generalized cellular swelling of brain parenchyma due to movement of water from hypotonic extracellular fluid to intracellular fluid, leading to cerebral edema and raised ICT. So symptoms usually are more dependent on the rapidity of development rather than the severity of hyponatremia. So when a patient is having acute hyponatremia, as you can see in the diagram besides, in acute hyponatremia, the patients tend to have cellular swelling due to acute decrease in plasma osmolality and movement of water from extracellular to intracellular, hypotonic movement. So this leads to cellular swelling and cerebral edema develops. Whereas in gradual hyponatremia, that is chronic hyponatremia, initially the cell tries to compensate by losing osmolytes, which again reduces the intracellular osmolality, and decreased water tends to go inside the cell, and the cellular swelling is less. So the cell sizes are maintained and no cerebral edema is seen in chronic hyponatremia or gradual hyponatremia. So patients having acute hyponatremia are more prone for cerebral edema development than as compared to the chronic hyponatremia. So symptoms usually moderate to severe symptoms will include nausea without vomiting, confusion, and headache. Whereas in severe symptoms, vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizures, coma. So our patient, which we discussed before, presented to us with vomiting and altered sensorium, that is abnormal and deep somnolence. So she was a case of severe hyponatremia, and that was acute in development also. So acute hyponatremia, the causes are first of all iatrogenic, that is in postoperative premenopausal women, hypotonic fluids in patients having increased ADH secretion, glycine irrigation as in TERP, colonoscopy preparation, polydipsia, MDMA ingestion. MDMA is a potent stimulator of thirst and ADH, that's why it can lead to acute hyponatremia. Exercise-induced multifactorial, that is thiazide. Recent initiation of thiazide diuretic can also cause acute hyponatremia. So persistent chronic hyponatremia, that is, it is defined by a time period limit of more than 48 hours because the time taker for the cellular adjustment is usually 48 hours. That's why it is labeled when there is a persistence of symptoms more than 48 hours. So as explained before, in chronic hyponatremia, the cells try to adapt by effluxing of the organic osmolytes, which can include creat, betaine, glutamate, myoinositol, and taurine. It usually occurs within 48 hours, can be symptomatic or can be asymptomatic. Symptoms such as vomiting, confusion, seizures can be there. So if patient is asymptomatic, it is called as chronic asymptomatic hyponatremia. But if asymptomatic, question arises, should we treat them? Because patient is not having any symptoms, so is it good to treat or not? So the answer for that is yes. We should always treat a patient with chronic asymptomatic hyponatremia also, because there is risk of fall and bony fractures due to the hyponatremia associated reduction in bone density, and it can lead to increased morbidity. So yes, we will treat a patient with chronic asymptomatic hyponatremia. So this is a figure which represents the effects of acute and chronic hyponatremia on brain. So initially, a brain with normal osmolality, when there is hyponatremia, the osmolality is less and the cellular swelling tends to develop, but for which the rapid adaptation, brain tries to rapidly adapt by excreting the interstitial fluid into the CSF, which again goes into the intravascular volume, systemic circulation. And if this rapid adaptation fails, then or the hyponatremia persists for more duration, then the second line of defense is loss of sodium, potassium, and chloride. That is from the brain cells, which leads to cellular hypotonicity, which and then the third line of defense for this is loss of organic osmolytes, which we have seen in the chronic hyponatremia. If this state, if proper therapy is given, then patient can have normal osmolality and normal brain. But if the therapy is not given properly, that is, if there is rapid correction or very slow correction, then it can lead to osmotic demyelination. So diagnostic evaluation for hyponatremia, first of all, the first and foremost thing is drug history and clinical assessment of volume status. So drug history, like those of diuretics, SSRIs, then in blood investigation, serum osmolality to differentiate between various types of hyponatremia. Then one creat to rule out any renal causes, serum potassium to rule out primary adrenal insufficiency, serum glucose for the relative concentration. So for every 100 milligram per deciliter rise in glucose above 100, there is correction of 2.4 milliequivalent per liter of sodium. So that has to be corrected. Serum uric acid to differentiate between SIDH and cerebral salt wasting. Thyroid profile and adrenal function for the endocrine causes of hyponatremia. Then radiological imaging to rule out any pulmonary or CNS cause of SIDH or hyponatremia. And then the other investigation, that is urinary sodium, is particularly important because in SIDH it is characteristically more than 30 millimoles. And hypovolemic hyponatremia, it will always be less than 20 because kidneys tries to retain the sodium and water. In thiazide, it can be more than 20 millimoles. And in beer potomania, it is usually less than 20 with very low urine osmolarity of less than 100. So there often is confusion between SIDH versus polydipsia because both leads to free water, increase in free water of the serum. So in SIDH, urine osmolality will be characteristically more than 400, whereas in polydipsia, it will be less than 100. So, but if it is between 100 to 400, it can be a combination of both also. So treatment wise, so while treating hyponatremia, there are one has to keep in consider the following things very precisely. That is, the presence and severity of symptoms should decide about the urgency and our goals of therapy, means how much sodium we want to correct over a period of time. Then chronic hyponatremia has a risk of developing osmotic demyelination syndrome if rapidly corrected, and response to treatment is highly unpredictable, and therefore frequent monitoring is always necessary in while treating these patients. So the treatment for euvolemic hyponatremia, like hypothyroid, secondary adrenal insufficiency, SIDH, is to treat underlying causes. For hypovolemic hyponatremia, IV hydration with normal saline will do the job, and as it will rapidly reduce the ADH and diuresis, leading to correction. In hypervolemic hyponatremia, as per the cause, like if patient is having some cardiac causes like cardiomyopathy, then we can increase the ACE inhibitor therapy, or in patients with having volume retention due to renal causes, we can have diuretics. So that can lead to correction. In patients with low salt intake, like beer protomania patient, IV hydration with normal saline and resumptions of normal feed will usually do the work. And there is high risk of osmotic demyelination syndrome in these patients, like alcoholics, hypokalemic, malnourished, because there is a theory that which says patients having chronically malnutrition, their ganglia cells are depleted with sodium potassium ATPase pump, which prevents cellular swelling while the correction of the hyponatremia. So these patients are more prone to have ODS, means osmotic demyelination syndrome. So in treatment options, first, water deprivation has been traditionally been a cornerstone of treatment, but it is difficult to execute as there is the thirst stimulation is inappropriate, and it is difficult to tell a patient to remain, means to just bear the thirst. So for this, how much water should be restricted? How much water intake should be restricted? It depends on the urine plasma electrolyte ratio, that is urinary sodium plus potassium upon plasma sodium ratio. So if the ratio is more than 1, we need to restrict the water intake to less than 500. If it is somewhere equal to 1, we need to restrict water intake up to 500 to 700. And if the ratio is less than 1, we need to restrict the water intake to less than 1 liter per day. So potassium replacement in hypokalemia, that will again help in sodium retention. Increasing dietary solute intakes like oral salt tablets or palatable oral urea tablets, which are available. Combined furosemide and oral salt tablets. So furosemide will inhibit the countercurrent mechanism, and it blunts the urinary concentrating ability, and thus leading to the washout of water, and the salt takes care of the sodium lost in the urine. Demeclocycline, it is an inhibitor of principal cells in collecting ducts, which leads to excessive natriuresis and is avoided in cirrhosis and have increased risk of nephrotoxicity. Vaptans, that is V2 receptor antagonist, tolvaptan, that is a oral vaptan available, which is a V2 receptor antagonist, whereas the second is a conivaptan, which is a IV vaptan. It acts on both V1A and V2 receptors. These are indicated in SIDH and hypervolemic hyponatremia. This is not useful in hypovolemic hyponatremia and acute hyponatremia. So along with vaptans, one should also liberalize fluid therapy, because if one is using a vaptan and also along with that we are restricting fluid, it can cause acute rise and may also cause hypernatremia. So it should be used for only 1 to 2 months because of risk of liver injury. So treatment of acute hyponatremia, there is no role of ADH antagonist. 3% normal saline can be used, but we have to keep in mind that the rate of correction should be 1 to 2 millimoles per hour for maximum of 4 to 6 millimoles. And this usually elevates the acute symptoms, and this should be followed by slow correction. So sodium deficit is calculated by formula 0.6 into body weight into the deficit of sodium. So rate of sodium is usually highly unpredictable, therefore values should be repeated every 4 to 6 hourly in the initial phase. oxygen and ventilatory support wherever necessary in some patients developing pulmonary edema or for airway protection. IV loop diuretics again can help in treatment. Treatment of chronic hyponatremia. So this should be corrected gradually as patient, no acute correction should be advised as patient have been chronically ill with that, and correction rate of 8 to 10 millimoles per 24 hours or less than 18 in 48 hours is usually recommended to reduce risk of osmotic demyelination syndrome. Further, lower target in high-risk cases like alcoholics and malnutrition with hypokalemia. So back to case, considering the lab findings in our
Okay,
patients.
listen.
Jayant,
Wait.
I think we
Listen,
have to.
Arindam,
Yes, sir.
yeah, I'm on the road, so there could be some disturbance. But
Yes.
I think if you hear a lot of disturbance, tell me, I'll stop. Otherwise, I'll just have to make a few comments here.
Sir, I was wondering that Dr. David has joined. Should I ask him to comment first and then you can put your.
Sure. Yeah, let
Okay,
David go
because
first.
I specifically invited David to give for his point of view.
Okay,
And
sure.
and then I think you can comment on David's comment and combine together.
Okay, go ahead.
Dr. David,
Yes, sir.
please, if you can give your quick wisdom on the overall hyponatremia, the practical points, what our both consultants and our residents should know. And we have residents from all the departments, medicine, emergency, critical care. So, and then Rushi sir will give his point of view on a nephrologist domain. And obviously, Dr. Pandit is also there. So we need to have different viewpoints from all of you, endocrinologist, nephrologist, and critical care.
So from my side, the most important thing first is when a patient comes to you, assess the volume status. Depending on that, we then classify euvolumic, hypervolumic, hypovolumic. The most common group of patients would be euvolumic. Now, in this group of patients, it's important again we check up the serum osmolality, urine osmolality. Many patients you'll have like this presentation, but the serum osmolality and serum sodium both are on the lower side. The urine osmolality and the urine sodium will be on the higher side. Now, before we label everyone as SIDH, it is very important that we look into the cortisol axis and the thyroid axis. Many times we forget to do that and we miss out on hypocortisolemia. TSH we do routinely. So we should make it a point to evaluate this cortisol axis. And some patients may have adrenal insufficiency. And if you correct that, definitely there'll be a significant improvement. Many times we just reflexly start the patient on tolvaptan. So that's one thing that we need to remember. That one small point from my side, otherwise fine.
Okay, so we'll get back to you once again when we go to the case, because a lot of things would be happening in this case itself. Rushi sir, please.
Right. So I think few points to remember. First and foremost, the number. See, whatever I'm saying now applies mainly to euvolemic hyponatremia. First, every hyponatremia should be treated as chronic unless proven otherwise. Okay, there's no such acute hyponatremia unless you have clear documentation in your own institute. Label every hyponatremia and think of them as chronic. It's very important. Number one. Number two is look at the value of sodium, and that will and the patient's clinical symptoms. So if the sodium is below 120, okay, that's a orange zone. If the sodium is below 110, that's a red zone. So that will tell you about the chances of them getting into an ODS. So if it is 120 and above, then the chances of getting an ODS are fairly less, and you can just continue. Everything else you said would apply there, and you can go with the therapy. Now, important things are, A, the patient, if the sodium you are managing is below 110, the patient should be in a monitored unit. Second, insist on having an indwelling catheter for hourly urine output. Hourly urine output is a cornerstone of therapy of hyponatremia. Okay, so you must have a urinary catheter for hourly urine output monitoring. Today, it is easy to overtreat because of the availability of the Vaptans. So all this thing, that we do, calculating the sodium deficit, looking at the free electrolyte water clearance in the urine, that is all great. But what is important is to prevent a rapid rise in sodium at all costs. And that will only happen if there is polyuria. So in my own practice, I look at the urine in terms of body weight. If the patient is passing more than 2 times, suppose somebody is 70 kilos and they are passing more than 140 ml per hour, that's the onset of polyuria for that patient. So the next important corollary to remember is you should always have access to desmopressin when you are treating a patient with severe hyponatremia. So A, monitored unit, B, indwelling catheter for urine output monitoring, C, availability of desmopressin if the polyuria sets in. Because you don't want to see what happens. This, when you understood the whole physiology of increased ADH secretion, we have to understand that there is always a set point. And when you start correcting the sodium, at some point the set point just is reached and the ADH secretion stops. Now you remember the ADH has a very short half-life. So if your ADH secretion is shut off because of a rapid rise in sodium, and that rapid rise is different in different patients. So it is not possible to always predict that, oh, my sodium only went up by 3-4 points, but the patient had so much polyuria. So it shuts off, it's difficult to predict. So it's important to remember that output monitoring is mandatory. Because if that set point is reached and the ADH secretion shuts off, you suddenly have massive polyuria. And once that phase is reached, and if you are not monitoring, your patient is passing half a liter, 1 liter per hour for a few hours, in 6 hours the game is over. Understand? So it is very important for all of us to remember that correcting sodium when the sodium is below 110 or with neurologic symptoms is a medical emergency. And we must remember that sodium correction is important because of the risk of ODS and medical legal liabilities. It is very easy to prove in a court of law if you have erred in correcting the sodium. Okay, so please remember all of these points. And if anybody has any doubts on this, please ask later. Back to you, Arindam.
Fine, I think let's get back to the case, and then we will involve Dr. Pandit also, and obviously David. So Jayant, please continue. Let's see what happens to the patient.
So the laboratory parameters, considering the laboratory parameters, which was serum sodium of 98 in severe hyponatremia with a hypotonic osmolarity, IVC screening suggestive of collapsed IVC with a history of vomiting, urine osmolarity of 200, urine spot sodium 24, more or less in the range of, more or less near 20 only, uric acid of 4.6, and hypocalcemia, hypophosphatemia, and hypomagnesemia. Patient must means initially kept as a diagnosis of hypovolemic hyponatremia only. So she was initially given 3% NS owing to the severe hyponatremia, and her symptoms means she was stuporous only. So only 100 ml of 3% NS was given over 8 to 10 hours. Which was followed by slow correction with normal saline. So patient was discharged in a conscious state after 12 days with serum sodium levels of 134. So from 98 to 134, this sodium correction was done over a period of 10 days. So next topic for today is osmotic demyelination syndrome, a short topic, short presentation for this. So this occurs due to rapid correction, which is defined as 8 to 10 millimoles in 24 hours or more than 18 millimoles in 48 hours. This is caused due to the degenerative loss of oligodendrocytes within CNS, and it occurs. It does not present acutely, means so as if the patient sodium got corrected by more than 10 in 24 hours, the patient won't present to us in the next day only with the symptoms, but it will take some time for it to present to us. Usually it takes more than 24 hours after rapid correction. Most common site is pons. Other sites are cerebellum, geniculate body, thalamus, putamen, and cerebral cortex. So the clinical features associated with this are paraparesis, quadriparesis, dysphagia, dysarthria, diplopia, Lockton syndrome, and loss of consciousness. Other symptoms occur as per the site involved, like ataxia, mutism, dystonia, Parkinsonism, catatonia. The risk factors for osmotic demyelination syndrome, again, alcoholics, malnutrition, hypokalemia, hypophosphatemia, and liver transplant patients. So treatment to prevent osmotic demyelination syndrome is re-lowering the after overcorrection of sodium with the use of dextrose 5%, or AVP agonist, that is desmopressin. So there are three causes for overcorrection. That is, first is treatment of chronic hypovolemic hyponatremia with NS. Second is secondary adrenal failure with glucocorticoids. And third is Vaptan treatment plus non-liberalization of fluid. So treatment is aimed to prevent or reverse the development of osmotic demyelination syndrome, which can be done with help of AVP agonist, that is desmopressin, and free water or D5 dextrose 5% IV fluid. So our patient, she was discharged and she again presented to ER with complaints of delirium and irrelevant talking after 2 days of discharge. All routine investigations were done; those were normal. Again, neuroimaging was done, which was suggestive of hyperintensities in basal ganglia and caudate nucleus, along with gyral thickening involving bilateral temporal lobes, which were suggestive of extrapontine myelinosis. So patient was treated symptomatically with atypical antipsychotics and sertraline, and discharged with relatives being explained regarding poor reversibility of myelinosis. So these are two articles published in NEGM in 2023 only. So the first article is regarding osmotic demyelination syndrome in patients with hyponatremia. So amongst 28,858 hospitalization which were with hyponatremia, so there was overall rapid correction of sodium occurred in 3,600 patients, but only 12 patients developed osmotic demyelination syndrome, and 7 patients who developed ODS did not have rapid correction of serum sodium. So in all, only 5 patients who had rapid correction of serum sodium developed osmotic demyelination syndrome. So though the rapid correction of serum sodium was common, but osmotic demyelination syndrome was rare. So they have concluded that further studies are needed with higher number of patients to understand potential causal factors for ODS. Another study which has been published in NEGM only on 26 September. So they have included 3,274 patients, and then distributed them in 3 groups who had correction rate of less than 6 milliequivalent, then 6 to 10, and more than 10. So when they have compared group having 6 to 10 milliequivalent with a correction rate of 6 milliequivalent, so there was higher in hospital mortality and mortality in patients having correction rate less than 6 milliequivalent. And in patients who had and in comparison with 6 to 10 milliequivalent with 10 milliequivalent, so the correction rate of greater than 10 was associated with lower in hospital mortality and shorter length of stay. So 7 patients amongst all 3,274 patients, 7 patients had central pontine myelinosis, with 5 of 7 developing despite a correction sodium correction rate less than or equal to 8. So 5 of 7 developing less than or equal to 8, and 6 of 7 developed CPM. And amongst this 7 patients, 6 had alcohol use disorder, malnutrition, hypokalemia, or hypophosphatemia. So the conclusion they have derived is limiting the sodium correction rate was associated with higher mortality and longer length of stay, and whether the sodium correction rate influences neurologic complication needs further evaluation. But they have kind of proved that alcohol use disorder, malnutrition, hypokalemia, or hypophosphatemia is associated with higher risk of central pontine myelinosis. So our patient also had hypophosphatemia. So most probably that could have been that might have predisposed her to extrapontine myelinosis in spite of slow correction of sodium. Thank you.
Okay, so before I ask our clinical experts today, I think, can I have Dheeraj? You have seen the patient, so if you have some comments on.
I think Jayant has covered
Yes.
the pathophysiology and presentation very well. And you only said in the beginning, in the first slide of the patient, that patient was clearly a case of hypovolumic hyponatremia. So I think IV fluid correction was the right stay. I don't know, 3% initial. I understand it was very low. So initially, whether we should have just observed with the normal saline the rise, and then maybe after 12 hours take a call of using 3% initial. That is the only comment. Just I think Dr. Rushi Deshpande has given very practical tips, other things, apart from the theoretical. That's the only thing I have.
Okay, but any
If this would have been
questions?
other way, SIDH and all, I can understand, but this was looking like more or less hypovolumic according to the picture. And later on, I think it was turned out to be cerebral salt wasting syndrome, too much of polyuria. As Dr. Rishi Deshpande pointed out, with that polyuria phase, whether we could have intervened with desmopressin earlier to prevent even rapid correction. Those are the questions which come in.
Okay, Dr. David, and there are two questions. So obviously the second question is that if anything could have been done in a different way. And but primarily the first question is that do you think it is quite at times that we forget or we ignore that fact that maybe a rapid decline in sodium can also cause a demyelination? Or which one is more important, a rapid decline or a rapid correction?
So both are equally important. Like we get to see, osmotic demyelination and extrapontine demyelination with both. But literature always talks more with the correction. But we have seen cases with both, with severe drop in the sodium and with severe correction. With both, we can get to see osmotic demyelination. And of late, we get to see a lot of patients where the MRI findings are quite obvious. Clinically, the symptoms may be quite subtle. So we are picking up a lot of patients, where in MRI when we get this changes of demyelination seen.
And obviously, as the drop is not always in our hand, right? And most of the times the correction is more of an active process, and that can be contained and controlled. So I think we normally do focus on the correction itself, and we all know the standard rates and all others. But due to a lot of other factors which actually contributes to the rise of sodium, so normally it cannot be completely predicted. And that is the reason you always guide us that to do a more frequent sodium check. Uh, on that note, this patient was also given your desmopressin. Is there any role or that at times desmopressin can be given to check the very rapid rise? David, what would be your suggestion?
Yes, so it is to roll back the rapid correction in case you feel that over 6 to 8 hours you have met the target of 24 hours, or you've got a correction of maybe 6 to 8 milliequivalents. Then there again you give the desmopressin, you hold the water back in the body, and you dilute the sodium. So we could give it only if needed to roll it back.
Dr. Rushi, Rushi sir.
Yeah, I'm with you.
Okay, Rusi sir, we have also seen that if unfortunately, many of your hyponatremia patient, if they require dialysis, right? It's a very practical problem. I think most of our residents and fellows should know. And then we initiate a dialysis on that part. The dialysate sodium is on the normal in and around 135 to 140. So what would happen? Will they equilibrate and the sodium would rise very rapidly? And if it is so, how we can prevent that?
Excellent question, Arindam. But before I go there, I will again reiterate the same point.
Okay, sir.
Desmopressin for use of hyponatremia. Please remember, do not wait for the sodium report to come back and tell you that overcorrection has happened. You can see it a lot earlier if you are measuring the urine output per hour. Anything more than 2 times the body weight per hour is polyuria. Okay, please remember that point. Now, the second important point that Dr. Arindam asked me to speak about is how do I dialyze a patient with hyponatremia? Because all of you know the main thing that happens in dialysis is diffusion. So on one side of the dialyzer is the blood, on the other side is the dialysate. Now the dialysate sodium traditionally is between 135 to 140. But the machine can help you ramp the sodium up or down by adjusting the conductivity. So the lowest sodium that the machine can help you achieve is 126 or so in Fresenius machines. 128.6 to 128. That's what is practically achievable on the lower side. Now, what can be done to do dialysis but not have an overcorrection of sodium? Now, this is not mathematics, so it's not possible to tell that if I dialyze at so much blood flow, so much sodium against such a dialysate, what will be the 100% correction in sodium? It's not possible. So all that you can do is to reduce the efficiency of the sodium correction is reduce the blood flow, reduce the dialysate flow, reduce the time, and try and make the dialysis co-current. Co-current means in the same direction as the blood flow. Because all of these we normally do to decrease the dialysis disequilibrium syndrome. You must have realized that by now. So to prevent dialysis disequilibrium syndrome, all that we can do the same things to do slower correction of sodium. So less time on dialysis, lower blood flow, lower dialysate flow, and co-current flow of dialysate. Co-current means same direction as the blood. Normally, you always put them in opposite direction, so you get maximum efficiency. But when you want to minimize efficiency, you put them in the same direction. Correct? So that because the diffusion gradient is lesser over the length of the dialyzer membrane. So these are things that you can practically do. Now,
practically, can we ask our technician to do a rather than a counter current, do a co-current?
yeah, very easily.
Okay, sir. So that means the both the fluids are flowing in the similar direction, and there is no washout of the solutes, and the solute clearance is overall gets
Slower.
a little slower on the
It all
slower
depends
part.
on, Arindam, what was your indication for dialyzing a patient with severe hyponatremia? Particularly if somebody is less than 110, I would like to delay the dialysis.
Okay.
So if there
So
is
more
serious
practical is
indication,
that you will try to defer it till the time it is corrected and it comes closer to the normalcy.
yeah, 120. See, my thing is very simple. Below 110 red, below 120 orange, above 120, I'm not so worried of any of these ODS and whatnot happening.
And both your demyelination and disequilibrium are similar in NA. It's more of a movement of the solutes, rapid movement of the
So
solutes.
disequilibrium is urea and
Ah,
a sodium, and here ODS is only sodium.
only sodium. So you guys, please remember that you have to slow the movement of the solutes itself, right? Whichever way you can do it on that part. Okay,
Yeah.
so coming to Dheeraj, you are still there, and also Tushar is there. So is there any predilection that whether we have seen both central and your pontine and extra pontine, right? As I think David unfortunately had to leave, so I would be asking both of you that do you think that we can what sort of symptoms that can be there, both in pontine and extra pontine, and what could be the prognosis of or a long-term outcome of this patient. Rushi sir, please give your comment at the end. Dheeraj?
Whatever we have seen, patient can have any symptoms, ataxia. We have seen one alcoholic patient who had come with loose motions, and we did not do anything. We just were giving as the usual thing with IV fluids, NS, RL, and at that time we were presented with sodium of maybe 124, 126, and next day we observed it became 134 and then 138. And after 4-5 days, not 4-5 days, after 10 days, he came with ataxia, and then we could find out that ODS. So as Dr. Rishi sir said, 2-3 very practical points. Less than 110, it's more chances. Whatever you do, I think the few of the patient will land up into this problem. And less than 120 orange zone. But they can present, what I've seen is severe ODS, they will have quadriplegia like locked-in syndrome, as Dr. Jain pointed out. And this patient had irritability, maybe extrapontine pontine myelinosis was seen with psychosis and other things. So I think they can have varied presentation wherever the involvement of demyelination is there. But I still want to reiterate, I like the Dr. Rishi sir's point. I agree we use desmopressin, but what we faltered over here, I remember second day the patient was pouring a lot of urine, like 250, 300, and patient in fact had gone into mild hypotension. Briefly, she required NORAD, but at that time we did not use desmopressin. We used desmopressin, I think third day or so. We tried to overcorrect, do the overcorrection which we had done to reverse it. We had used 5% dextrose. I think there we little bit faltered. So this is a very important point which he said. I think urinary output, or maybe even if you're using 5% normal saline, sorry, 3% normal saline, simultaneously using desmopressin, it would also will not be a problem. Just to check over polyuriasis. That's what polyuria. That is the only point. I think that was a good point.
Tushar, please. I was anyway asking you to comment.
For this kind of scenario, definitely there are risk factors associated, like he described, alcohol and long-term dehydration or long-term malnutrition. But at the same time, the strategy usually divides in three phases. One is proactive, second is reactive, and third is rescue. Proactive, when, as Dr. Rishi told, the urine output increases, at that point of time, you use an desmopressin. Reactive is when you get the serum sodium, first serum sodium, which is just above your desired expected sodium to rise, where you can use dextrose 5% and desmopressin both. And rescue is where it actually has shot up. Actually has shot up, and where you need to use all this therapy, including 5% dextrose or whatsoever. So where proactive only has a good prognosis further going in that direction. And as you asked about what the symptoms is from the ranging from dysarthria to locked-in syndrome. It's a complete spectrum of involvement.
And regarding prognostication, Rushi sir, you have seen loads of patients who have come to you with hyponatremia. Many of them have had, unfortunately, rapid corrections. Some of them have actually come with demyelination. So what do you think in the follow-up? How did they fare?
Uh, Again, a very difficult question to answer. But by and large, most of them, it all depends on the degree of severity, what kind of injury they are presented with. And like Dr. Dheeraj, rightly pointed out, no, Dr. David pointed out that sometimes you can have MRI findings, but not much of clinical findings,
Right.
and vice versa. So that's important to remember, that the radiological and clinical science might not always match. Second, the radiologic findings come later than the clinical findings. Clinical findings always come early. So follow-ups after some time, can actually show the real picture. And in terms of recovery, it's very slow. You just have to try and keep that sodium around 130 to 135 range. and then just give them time, because there's nothing more to offer in terms of specific treatment. I mean, people have tried at, at the at the outset, when it happens, the sodium correction, if you see that happening and you are there, you should try and bring it down by 8 to 10 MEQ. Suppose it has gone up, by 16 MEQ, bring it down by 8. So 50%, you should bring it down from where you started. So if you have corrected by 20 MEQ, bring it down by 10. So something like that. And try and keep it the correction very slow from there on. I feel, that most of the times the mistakes happen because we try to treat just because of time pressure. So that should be avoided. We should never try to treat because of that. I'm not achieving a good correction with my traditional means, to do something extra, like give 3%. Is the patient is symptomatic. The second important thing to remember is the response to tolvaptan is unpredictable. So somebody might respond to a 1/4 tablet of tolvaptan in a very violent manner, significant polyuria, and somebody might not respond to 15 milligrams twice a day. So there is another thing I have observed in practice, that when you start off to treat hyponatremia, treat everybody as if they are exquisitely sensitive to tolvaptan. Start with a very small dose. If no response in 2-3 hours, increase it. That is just one practical take-home thing for all of us.
Fair enough. Any specific, Dheeraj, are you aware that any specific medications that can be used to sort of treat ODS, or to help to get recover from ODS rather than treat?
No, no, no. I am not aware. Whatever I've seen, like Dr. Rishi sir said, very severe. If there is ODS, then the recovery is not there. And only mild ODS, I've seen them recovering slowly with time. Like though I said that alcoholic that ataxia improved, but otherwise nothing. I don't know. Some such people say solumetanol, but I don't think so. It's just
No,
time.
we tried to
Physiotherapy.
find, Dheeraj, we tried to find out. There are anecdotal reports on steroids, but not clearly any. Obviously, you cannot have a sort of evidence-based very much. So you have anecdotal reports, but not very helpful. IVIG also have been tried. Hydrotropin releasing hormone TRH had been tried, and there are certain others. MABs have been very experimental basis, not in non-human trials, have been in being investigated. But obviously, we all know that it is very difficult to treat something which has got so much of varied presentation. The other thing, Dheeraj, what we were intrigued, and so Rushi said, this patient was pregnant, right? This patient is still was pregnant, and the pregnancy was around 12 weeks, right? So we were also thinking that whether this hyponatremia can have effect on the the fetus itself, the development of the fetus. Any comment on this one? And if it's so, how do we diagnose that? Anyone, any comment?
No personal experience.
No, nothing. Yeah.
That's very difficult to say.
Question,
So
yeah.
one postulation was that that the myelination develops after a certain period.
Yeah,
So
but this
if
is
you
only
do
12
not have
weeks, you said, na? It is only
yes, sir,
12 weeks pregnancy.
it's after 12
So,
weeks myelination develops.
exactly. So
So
you would not have so much injury, I suppose.
so that could be a blessing in disguise, right? And the
Yeah.
other thing is that to also we try to find out that whether there is any injury or not. How do we know the fetal itself? Because it could be a very important decision to know whether the fetal brain has certain injury. So if it had happened in a fetus of when the pregnancy is in the second trimester, 20 weeks and onwards, right, where the myelin sheath has developed. So also we came to know that there are centers where fetal MRI is also being done, which can considerably diagnose ODS
Yeah,
in fetal area. So those were the certain things we also studied and came to know. I think if there is no other comment or questions, then we can
Just one comment. I think what I
Yes,
have done
please.
practical, like Dr. Rishi sir gave very good practical point. I am talking of chronic hyponatremia, not the acute one. Just water restriction, I tell them, I find that is beautiful. And I think with the tolvaptans, unlike the rapid correction, it is very gradual correction. That's why we are not seeing that much of ODS problem with tolvaptans. That is the only thing. I'm not encouraging too much of tolvaptan. My first strategy is to restrict water, especially in hypervolumic people, not the hypovolumic. Those we of course treat with IV fluids, and little salt intake more. But fluid restriction helps, and I think that slide he had presented, Dr. Jain, that was good.
So thank you. And
Bye, Arindam. Thank
bye.
you.
Thank you.